Welcome back to The Unseen Burden. I'm Jake, your host, and today we're joined by Rachel, a leading expert in palliative care. Rachel, it's wonderful to have you here.
Thank you, Jake. It's a privilege to be here and discuss such a vital yet often overlooked aspect of patient care.
Indeed, our conversation today centers on the profound impact of mental health conditions within palliative care. It's a subject many might not immediately connect, but the prevalence is quite surprising, isn't it?
Absolutely. When we talk about serious illness, the focus often remains on physical symptoms. However, the emotional and psychological toll is immense, and it significantly affects quality of life for both patients and their families. It's truly an unseen burden.
It truly is, Rachel. And when we talk about this unseen burden, what specific mental health conditions are we seeing most frequently among individuals with serious illness? Are we talking primarily about mood and anxiety, or is the scope broader than that?
That's an excellent question, Jake. While significant mood and anxiety symptoms are indeed very prevalent, the scope is actually much broader. We also see conditions like psychotic disorders, personality disorders, trauma-related disorders, and substance use disorders, which are often less studied but incredibly impactful.
So it's not just the expected emotional distress, but a full spectrum of complex mental health challenges. How do these comorbidities, these co-occurring mental health issues, actually affect the patient's journey and their overall quality of life?
They have a profound impact. Mental health comorbidities are directly linked to adverse outcomes. Patients often experience a lower quality of life and, surprisingly, an increased physical symptom burden. It's a vicious cycle where mental distress can exacerbate physical pain and discomfort.
That's a critical point, that connection between mental and physical symptoms. Given this prevalence, how well equipped are our hospice and palliative medicine clinicians to manage these complex mental health needs in their daily practice?
Honestly, it's a significant challenge. HPM clinicians frequently encounter psychiatric symptoms, which often drive referrals to palliative care in the first place. However, there's a real lack of structural support.
What kind of structural support are we talking about specifically?
Well, things like readily available referral resources or integrated specialist clinicians within palliative care teams. Many clinicians also report low comfort levels in managing more complex mental health conditions, such as psychotic or personality disorders, which is understandable given the specialized training required.
It sounds like a systemic issue then, not just individual clinician comfort. What are some of the biggest barriers preventing patients from getting the mental health care they need within palliative settings?
You've hit on it, Jake. There are significant barriers to accessing specialty mental health care, compounded by a severe workforce shortage across the board. Also, the training for HPM clinicians in mental health care is often variable and, frankly, inadequate.
And I imagine stigma plays a role here too, doesn't it?
Absolutely. The stigma associated with mental health can unfortunately hinder open discussions and effective care delivery. Patients might be reluctant to bring it up, and sometimes clinicians might not feel equipped to initiate those conversations.
So we have this clear need and clear barriers. Are there any innovative approaches or interventions emerging that offer hope for better integration of mental health care into palliative settings?
Yes, there are some promising developments. Psychological interventions like cognitive behavioral and existential therapies are being adapted. On the pharmacologic side, we're seeing novel applications of antidepressants and ketamine, and there's growing interest in hallucinogens like psilocybin for certain conditions.
That's fascinating, especially the mention of psilocybin. Are there any other types of interventions gaining traction?
Indeed. Interventional psychiatric approaches, such as electroconvulsive therapy and repetitive transcranial magnetic stimulation, are also gaining interest for severe and treatment-resistant cases within palliative care. It's about exploring all avenues to alleviate suffering.
It sounds like the field is actively seeking solutions. A national survey of HPM clinicians recently highlighted some key insights into this issue. What did that survey reveal about their experiences and recommendations?
The survey really underscored the frequent encounters HPM clinicians have with mood, anxiety, and neurocognitive disorders. Crucially, respondents identified a strong need for increased integration with mental health specialists and significantly improved training opportunities for themselves.
So the clinicians themselves are asking for more support and better tools. What specific improvements were suggested to bridge these gaps?
They suggested streamlined referral systems, having embedded mental health specialists directly within palliative care teams, and enhanced training for palliative care clinicians. These are all practical steps that could make a huge difference.
Those sound like very actionable recommendations. Are there any specific models of care that are being proposed or implemented to achieve this better integration?
Absolutely. Integrated care models, like the collaborative care model, are highly recommended. These models focus on upskilling all palliative care clinicians to handle common issues, while also creating clear access to specialty care for those more complex cases.
And who would typically lead these integrated models?
Palliative care social workers are often ideally positioned to lead these models, supported by psychiatrists and psychologists. It's a team effort, leveraging the strengths of different disciplines to provide comprehensive care.
Rachel, this has been such an incredibly insightful conversation. We've really uncovered how mental health isn't just a secondary concern in palliative care, but a central, often overlooked component that impacts everything from physical symptoms to overall quality of life.
Absolutely, Jake. And it's clear that by embracing integrated care models, bringing in mental health specialists, and providing better training for our HPM clinicians, we can truly transform the experience for these patients. It's about ensuring a more holistic and compassionate approach.
It's a powerful reminder that true palliative care means caring for the whole person, mind and body. Thank you so much for shedding light on this critical area, Rachel, and for sharing your expertise with us today.
My pleasure, Jake. It's a conversation that needs to continue.
Indeed. And to our listeners, thank you for joining us on The Unseen Burden. We hope this discussion encourages you to reflect on the profound connection